Yeah, hello, doctor.
Hello, Meenal ji.
Yes, we are live now.
So, thank you for inviting me.
Yes. Hello and welcome all. Maatri is glad to host yet another webinar where we try to address the common concerns amongst our audience. Did you know that children, even infants, can get kidney stones? It is observed that the number of kidney stone cases in children has been increasing over a period of time. Kidney stones, if left untreated, can lead to several infections and may become a cause of other complications as well. We have today with us Dr. Sandeep Harkar, Senior Consultant Urology Department at Artemis Hospital. Welcome, Doctor. Over to you.
Thank you. Yes, I really find it a privilege to be part of this initiative by Maatri team, and I would be discussing a very pertinent and important topic today. And having a background of your group focusing primarily on maternal and child health, so I thought let me discuss the topic of stone disease with you, which is very common in our population, especially from the perspective of a mother and the pediatric population, that means the children. So I would like to present to you my slides, and whosoever has any confusion, any doubt, any clarification, you feel free to ask after the completion of the presentation, so that I think we should be able to clarify as many doubts as possible today.
Yes, I would like to request at this point all our viewers, they can pour in their questions, queries in the comment box, in the chat box, and we will take up all the questions after the presentation of Dr. Sandeep.
So should I begin?
Yes.
Yeah, Meenal, please let me know in case there is some issue with the audio or a video.
Yes, I will.
Okay.
Yeah.
So I should be presenting. Just a second. So are the slides visible?
Yes, very much.
Okay. So as I told you, so we should be discussing kidney stone diseases and general population as well, especially in the context of the pediatric age group, the children, and the pregnant women, maternal aspects. So, brief introduction, as Meenal has already told you, I am working as a senior consultant in urology and neurology and renal transplant at Artemis Hospital, Gurgaon. So, what a urologist deals with, to brief introduction about a urology branch, because there's sometimes a confusion between a person doesn't know whom to go to. If he has a kidney problem, should he go to a physician, should he go to a surgeon, should he go to a nephrologist, or should he go to a urologist? So urology as a branch deals with kidney stone disease, elderly patients having prostatic problems and urinary flow issues, cancers of the urinary tract ranging from kidney, bladder, prostate, male and female urinary tract infections, male infertility and sexual dysfunctions, and kidney transplantation in cases who have end-stage kidney disease. Coming to the topic of the day, as you all are aware, the stones come in a variety of forms. The kidney stone can be as small as a small grain of sand, or maybe as big as a golf ball. The surface can be smooth or can be ragged and jagged, and the color may vary from anywhere from brown to yellow and even black. So how big is the stone burden? You will be surprised to know that about 12% of the total population has been reported to be prone to urinary stones. So at any point of time, if you scan population in general, you might find around 10 to 12% people out of every 100 would be having stones. And out of these 12%, half of them would be affected severely with the stone disease. That means they might have some amount of kidney dysfunction, kidney problems because of the stones. So we have to consider the stone disease very seriously. Especially we in Haryana, we are part of what you call as stone belt. So northwestern parts of India fall into this belt where the prevalence of stone disease is quite high. And most of the members of a family would suffer from kidney disease, kidney stone disease at some point of time. So this I feel is a very important slide, because a lot of people don't even have an understanding about how do these kidney stones form, where are they coming from, where are the kidneys, to be very specific. I come across people who even ask, Dr. Saab, we eat healthy food, we eat normal clean food, we don't eat stones, so how come stones come into the kidney? So let me go to the basics. There are two kidneys in every individual, one on the right side, one on the left side of the abdomen, as you see in this picture. They are somewhere in the upper back, just below the rib cage. These are the factories for urine production. Urine is produced, blood is filtered here, and the urine is drained from the kidney through these small narrow tubes, which are called as ureters. So once the kidney produces urine, it trickles down through these ureters, one on the right, one on the left, down into the urinary bladder, which is the storage organ. It just stores the urine as it comes from above and keeps on filling up. We are not aware of this whole process going on continuously 24/7 in our body. We are just aware of the urination only when this bladder becomes full. That's the time when we feel that we have to go to the washroom and we have to empty the bladder. So this is the normal anatomy. Now if you see this kidney here in the other slide, from inside, the outer part, the red part, is the functioning part. This is where the blood gets filtered and urine is produced. Whatever urine is produced, this goes into the central part, that is the collecting part. So urine produced from the kidney now goes into the central pelvis area of the kidney, and this is where actually the problem starts. The kidney has the tendency, it is the function of getting rid of the body of the extra salts, extra minerals, toxins, and excess water. So these minerals get filtered from the kidney into this pelvis area. If the urine is concentrated, or if the amount of these minerals is very high in urine, then they do not remain soluble. These minerals are normally dissolved up in urine and they just go out. But sometimes if they do not remain soluble, they'll get precipitated. These crystals will get precipitated, right, and they will start joining with each other. Initially they are very small microscopic crystals of some elements like calcium oxalate, calcium phosphate, and these crystals are in dissolved form, and gradually they start joining with each other, they start precipitating and form tiny microscopic particles, right, which can be seen. So and then if the same process continues, then these stones start becoming big, 1 mm, 2 mm, 5 mm, 10 mm, and then they may start growing in the kidney, and one fine day these stones may actually get dislodged from the kidney and just go into this tube which I talked earlier, the ureter. They might get migrated down from the kidney into this tube and cause blockage of the tube, because this is just about 2 to 3 millimeter size or diameter of this tube. So any stone may get stuck up in this tube. This is when the patient actually feels the existence of a stone, because he starts developing pain. Till the time a small stone is in the kidney, it's slowly, gradually forming and growing, you may not even be aware of it. And when it comes down into the tube, it starts blocking the flow of urine. That's when the symptoms occur and patient rushes for treatment. So I feel this is the mechanism we all should be aware of, so as to have a better understanding of the kidney stone disease. Stones come in variety of forms, and the name of the stone is based on the crystal it is made up of, like calcium oxalate stone, calcium phosphate stone, uric acid, struvite, cystine. So I'll not go into these intricate details. Now we have understood how they are formed, but why they are formed. So kidney stones, primary, the most important cause is the family history. It has been seen that kidney stones develop, the incidence of kidney stones is quite high if there's a family background of stone disease. Also, decreased water intake. Exactly. This is the prolonged period of dehydration, or if the water intake is low, again the chances of stone formation is high. Urinary tract infection, diabetes, improper diet, obesity, and certain medical conditions. These all can lead to the increased incidence of stone formation. There are again some medical problems. They have a relevance in pediatric population especially. In children, the stones should not form, and if the stones are being formed in the pediatric age group, smaller children, 5 years, 10 years, 15 years, then most probably you will be able to find some inherent cause, some genetic or some medical condition which has to be explored, like these hyperparathyroidism, cystinuria, hyperoxaluria. All these conditions need to be evaluated in children, because in them the chance of recurrence is very high, and also we might be able to figure out the cause. In adults, finding a cause is really difficult. It's most of the times we don't find a cause, but in children, if a child of age of 5 years or 8 years is forming a stone, then definitely there is something wrong in the metabolism.
Right.
So let's come to the presentation. How does it present? As I told you earlier, about 40 to 50% of patients, the stone is lying in the kidney and you are not aware of it. So you do an ultrasound for some other thing and you come to know that there is a stone there. But when it presents, usually there is a pain in the back. It's a typical characteristic type of pain. A patient just hold that side of his lower back with his hand, and the pain goes down to the middle of the abdomen, to the lower part of the groin also. There may be associated nausea, vomiting. Patient feel pukish, and it's nothing wrong with the intestines. This is again a point I want to highlight. People land up into the emergency room of a hospital with vomitings and severe nausea, not able to digest anything, and the reason is a stone, because this is reflex vomiting because of the spasm of the ureters in these patients. Now, blood in urine can be a symptom. Patient may have microscopic or macroscopic, or that means you can see from a naked eye. Usually it's not very dense, very bright urination. It's just sometimes a cloudy urine or little turbid urine. Or patient may have problem with urination. He may feel that he wants to have a strong urge to pass urine very frequently. Again, in presentation, it can be very variable. Some people, especially diabetics, may not have pain, may not have any symptom. They just develop fever, and when you investigate, they have got infection in the kidney and because of obstructing stone. Once there is a suspicion of a stone disease, we need to confirm it. We may do some blood tests, an ultrasound, or actually the gold standard, the best investigation for a patient who has come with severe episode of pain is a CT scan of the abdomen. Why CT scan? Because a lot of stones, especially in the ureter, the tube which I talked of earlier on, the stones in the ureter can be missed on an ultrasound, because ultrasound as a modality does not pick up ureteric stones most of the times. About 40-50% time it can pick up, but otherwise it may not pick up. CT scan is the investigation, especially a non-contrast CT scan, which helps us in picking up the stones of any size, any location, and it tells us about the kidney function also at that time. In children and in patients who are recurrent stone formers, like your patient has a stone and again developed a stone a couple of years later, These are the people who need thorough investigation further than this, like they undergo a battery of blood tests, or 24 hours urinary collection is done, and then we analyze the metabolites, the minerals which are being excreted in large amounts in urine, and try to rectify those. So let us discuss about what can we do, how can we stop prevent formation of stones in the kidney. Here I would like to impress that practically as of now there's nothing which we can specifically do that you follow this regime of diet, you follow these medication and there'll be no stones in life. No, this is not possible. But yes, there are some risk factors which can be modified and they may help us to some extent. So what are the risk factors? Increased consumption of proteins, animal food, protein, increased carbohydrate intake like fructose, like some high syrups, high concentrated sugar syrups, and large amount of salt in the diet, especially in fast foods, in carbonated beverages. You find this excess sugars and salt, and these are some of the reasons why the incidence of stone formation is increasing in the pediatric population. It has been seen overall, worldwide, especially in the Western population. The incidence of stones has increased rapidly over the last 2 to 3 decades. Reason being the diet.
Right.
Oxalate rich food. Again, there are some vegetables, fruits which have high oxalate in them, which may lead to stone formation. Again, low calcium diet. This is little interesting. Low calcium diet is a risk factor. People who are low in calcium, who are taking low calcium in their food, may form kidney stones. I'll be discussing about it. Now, what are the protectors? Citric acid, potassium and magnesium. These minerals have been shown to have a mechanism in which they somehow protect the stone formation. They are inhibitors of stone formation. So coconut water, citrus fruits, oranges, lemon, they have the intake of these is good for preventing stones. A brief word about alcohol intake in general population. People have this this notion that alcohol drinks, beverages like even beer, taken in good amounts will prevent stone formation. No, it's absolutely a wrong notion. It's a myth. They might find it good because when you consume alcoholic beverages, you have diuresis, you form more of urine, and it acts as diuretic and may sometime clear the already impacted stone or something. But actually, in a long run, if somebody is consuming alcohol on a very frequent basis, then increased uric acid and increased oxalate excretion is occurring through the kidneys. And these are the minerals which actually get concentrated and form stones. Okay. So alcoholic beverages, strict no. Again, protein intake, as I told you, protein diet has more of uric acid. Some amino acids like glycine and all, they form more of oxalate and may actually lead to kidney stone formation. So protein diet is important. Balanced amount of protein intake is required for metabolism in the body, but greater consumption can increase the burden on the liver and the kidneys and lead to problems. Calcium intake and stones. I'm stressing on this slide specifically because people think that calcium is the culprit for stone formation.
Yes.
And they on their own stop taking calcium. Agar ek baar stone ho gaya, they stop taking calcium supplements, calcium in their diet, thinking that calcium they will form stones, but it's opposite. You know why? Because the stone is formed by combination of calcium with something else, like calcium and oxalate, calcium and phosphate.
Okay.
So culprit is the oxalate component, not the calcium.
Okay.
So we have to somewhere decrease the oxalate in our diet. And how does calcium help? So if we are taking calcium in our food and we are simultaneously consuming oxalate. Oxalate is present in a lot of foods, vegetables, tea, coffee, nuts. The oxalates is in plenty in our dietary foods. So once you consume calcium and oxalate, they both will get absorbed from the intestines as a normal process. So if there's calcium in the food, it will bind with the oxalate part in the intestines, and it will prevent oxalate absorption through the intestines. Okay. So in a way, calcium is benefiting, eating calcium in diet is benefiting by preventing absorption of oxalates from the intestines. And if the oxalate is not absorbed in the intestines, obviously the level of oxalates in the blood will be less and oxalate stones will be less. So on the reverse, if we stop taking calcium, the oxalate will be free. It will not be binding up with anything else. So it will be absorbed easily through the intestines.
Okay.
So this is only that group of people who have got recurrent stones and in whom we have proven that yes, calcium is excreted in the kidneys at a very, very high level. They need to decrease their dietary calcium. Otherwise, not always. And one word here is that calcium supplement should be taken with the meals. Okay. So here again the mechanism is the same. If you're taking with the meals, a part of it will be absorbed and part of it will help us to get rid of the oxalates.
Right.
Again, a word about carbohydrates. It has been seen that by certain mechanisms, I will not go into details, the increased intake of carbohydrates in diet will lead somehow to the formation of stones. So not too much of carbohydrate is good. There are some medical treatments in a particular group of patients where some medicine is started and they may not form stones, or the recurrence may be decreased. Now coming to treatment. So treatment depends on the stone size, stone location, stone composition. It has been seen that smaller size stones, usually less than 5 mm size, they might pass spontaneously. Body, the ureters have the capacity most of the times to just get rid of these stones which are less than 5 mm in size, and especially with the addition of some medications which dilate the ureter, which open up the tubes and help in spontaneous passage.
Right.
But the stones, as they grow higher in size, more than 5 mm, up to 10 mm, again the chances decrease. And the stone size which is more than 10 millimeters, the chances of spontaneous passage is less than 5%. So you can understand how it works. And it has been seen that most of the stones which have to pass spontaneously will pass within 4 weeks.
Okay.
After that, the chances of spontaneous passage of stones is extremely low, less than 5%.
Okay.
So those people who are waiting for stones to pass spontaneously over many months are actually doing harm. If the stone has not passed in a month, unlikely that it will pass by itself. So when we should not wait for spontaneous passage, we come across a lot of patients in the OPDs, in the emergencies, where with small stone, we give the medicine, ask them to wait. But there is a group of patients who should not wait. Like if there are stones which incidentally have come down from both the kidneys and have got stuck up in the ureters on both sides at the same time, that's an emergency, that we cannot wait. Or if the pain is not settling, you are giving a lot of painkillers, but it's not settling. A patient who has come with fever and obstructing stone in the ureter, this is an emergency. In this, we have to somehow relieve the obstruction, otherwise it will cause damage to the kidneys. Right. The patients who have already a compromised kidney function, again, they are a high-risk group where we should not wait for long. So, what are the indications for planned surgery? Planned surgery, like if the stone has not passed and is a significant size, around 10 millimeters, and we have tried the medical management, that's the time when we should start planning for surgery. Treatment alternatives. So what are the treatment alternatives? Briefly, I'll not go into details. There is something called as shockwave lithotripsy, ureteroscopy, and PCNL and laparoscopic removal. Gone are the days when you had to undergo a big cut with lot of stitches and then you remove a stone from the body. As of now, more than 95% of the patients can be treated with endoscopic procedures. So what are the procedures? A brief word. Lithotripsy is the minimally invasive and the simplest and the shortest way of stone removal, in which you do not do any intervention from inside. A patient is placed under a machine, and there are some waves which are focused onto the stone with the help of X-rays, which breaks the stone into something like small fragments or sand, dust, and which passes spontaneously in the urine. It is feasible for stones which are in the kidney or which are moderate size, 1 centimeter, 1.5 centimeter size, and are in a particular location of the kidneys where this lithotripsy works. And the stone should not be very hard. So on the basis of various factors, we come to a decision that yes, this is the patient who can get benefited by lithotripsy, and that's how we decide. Another method is retrograde intra-renal surgery. Like, it is a newer modality. It has come for last maybe a decade or so, in which we have a flexible instruments which go right up into the kidney from the normal passages, very, very thin sized instruments. They can be manipulated inside of a kidney, and with the help of laser, we focus on the stone, we break up into a very small dust-like particles, and then they are washed away. This is a laser machine, luminous, which we have in our centers, and they just fragment the stone into fine dust which is washed off. So no intervention from outside, everything from inside. Then for larger stones, if the stone has become big, it's about 1.5 centimeters. Then these endoscopic procedures won't be helpful. In this case, we had to just make a small cut in the back, about 1 centimeter, 1.5 centimeter big cut into the back, and then go make a passage right into the kidney, small hole in the kidney, which you call as a keyhole surgery also. And through this hole, you pass your instruments. It's actually a telescope only, but from a small hole, you put it into the telescope, you put it into laser, break up in the stone, and take it out.
Right.
So this is the method which is used for larger stones, whatever be the size, you are able to clear it. Now, what about the stones which are somewhere in the ureter, which is a very common presentation? Stones stuck up here in the tube, in the middle, in the lower part. Yes. Here we have again an endoscopic instrument which goes very, very thin, about 1 to 2 millimeter size of the instrument, which goes into the ureter. Under the camera, we see and break it with laser and clear it out. This is an image where you can see the stone within the ureter, which is being after fragmenting, which is being picked up with a forceps and removed.
Okay.
So this was briefly about the stone disease in general, and a word about kidney stone in pregnancy. Again, pregnancy is a condition when there are a lot of changes occurring inside the body, and management of this group of patients is crucial and challenging.
Right.
Because normal things don't work here. In the sense that the test, I said, the CT scan, which is commonly done for diagnosing of a kidney stone in a ureteric stone in a normal population, cannot be used in pregnant patients because of radiation exposure. So you have to make decisions on the basis of ultrasound and other clinical parameters. So what is the prevalence? 1 in 200 or 1 in 1500 pregnancies may develop a stone in the kidneys during the pregnancy and cause problems. So kidneys, the pain because of kidney stone, which is obstructing the ureter, is the most common non-obstetrical cause of hospitalization in pregnant female. You can understand the importance of this. Like if a pregnant female develops pain in the abdomen, it can be either because of the obstetrical cause, the fetus, and the second most common cause is the renal colic, the stone pain. And converse to the general population, which forms calcium oxalate stones most of the time, about 80 to 90% of times. But in pregnancy, the commonest stone variety is calcium phosphate. Nature has somehow tried to balance the various mineral mechanisms regulation of the various minerals in the body during pregnancy. There are some things which promote stone formation, like there are various hormones which are produced during pregnancy. They lead to stasis, they lead to little slowing down of the flow of urine, and hence may lead to more of calcium deposition, calcium oxalate deposition, and precipitation. But at the same time, there is increase in various elements like citrate in urine, which prevents stone formation. But somehow, in some people, this balance may get disturbed and lead to stone formation. What are the obstetrical effects? So, if a patient develops stone pain, an obstructing stone in the kidneys during pregnancy, they have increased chance of developing preterm labor. They have preterm deliveries. There may be early rupture of membranes, or there may be, the process of pregnancy, the delivery may be expedited, and a patient may develop preeclampsia. This is like a condition in which the blood pressure and other parameters, they go high, and that's risking the baby.
Okay.
So how to diagnose? As I told you, ultrasound remains the cornerstone of diagnosis during pregnancy. And treatment. In pregnancy, the conservative management is the treatment of choice, usually by hydration, giving good amount of water so that the stone may get flushed out. Pain relief, we can't give normal painkillers like Voron and other pain medicines. There are different group of medicines which can be given in pregnancy, and some other medicines which may help in passing of stone. But for this group, again, those people who only those patients can be tried with this who follow this criteria. Stone is small, there is no infection, there is no fever. Patient oral pain medications are helpful in controlling the pain, and patient is able to eat and drink. If there's repeated vomitings, then you have to really intervene. But again, while on the conservative management, patient has to be really closely monitored for any signs of infection, any signs of obstruction, and intervene accordingly. And how, as I told you, again, the same. There's infection, fever, obstruction, refractory pain, then is the time to intervene. Now, how do we intervene during pregnancy? So there are two ways, either by temporary diversion or by actually removing all the stone. So temporary diversion means putting a stent. Now, how do we put a stent? Suppose this is the image, if you can see on the side of the screen. The kidney, it has a stone somewhere in the ureter stuck up. Mm-hmm. So ideally you go inside and remove the stone, but that is a major procedure, and if the patient is not fit or very early in the pregnancy or very late in the pregnancy, you can't do a major procedure. Mm-hmm. So what you do at that time is that you go inside, it takes maybe a 10 or 15 minute procedure. You put a stent inside the ureter, which is a very thin silicone tube, which diverts the urine. It allows the passage of urine from the kidney through the ureters alongside the stone into the bladder. So the emergency is averted and the pregnancy can be continued, so that the stone can be handled maybe at a better period of the pregnancy or after delivery. Right. Again, if there is a lot of infection, stone is stuck up, we have done it sometimes, that the stone is stuck up, the stenting cannot be done, there's infection in the kidney, there's pus in the kidney because of blockage, then we have to put a tube from the outside, which is called a percutaneous nephrostomy, for some time. Okay. And because of the better instrumentation, better obstetrical care, good endoscopies, better medicines, nowadays doing a definitive treatment during pregnancy is also possible. We have done it many times. In the second trimester, that means from 3rd to 6th months, that is a safe period for intervention. If there is a stone stuck up in the ureter and needs to be removed urgently, then we can go do a ureteroscopy. As I told you, go with the endoscope into the ureter under anesthesia. But it has to be done with a total teamwork between the obstetrician, a neonatologist, anesthetist, and the urologist. Right. So coming to the messages I want to convey to all, to the audience today, the most important part is the drinking adequate water. It is the most important lifestyle change which can be done to prevent stone formation. And the target should be that urine output in 24 hours should be around 2 liters. Okay. So eating a healthy, balanced diet, as I spoke, what are the diet which you should consume? Limiting intake of oxalate. There are some foods which have high oxalate in them: spinach, tea, chocolate, nuts, coffee, chocolates, and these are the things which you can consume. It's not that it's a total no, but in moderation. Stone disease in children should be evaluated thoroughly, as the chance of recurrence is very high and the chance of finding a cause is high. So it's better to get the child complete thorough evaluation done. Obstructing stones with urine infection. This is an emergency. If the stone is obstructing the ureter and there's fever, there's pain in the back and fever, that means that something is wrong. We cannot afford to wait and watch. That we need to timely intervene. And timely checkups and intervention is required in the sense that if you do a routine checkup and you find a very small stone in the kidney, that can be managed with medicines, that can be managed with lithotripsy, which is least invasive, and you can get rid of the stone rather than letting it stay there, getting it bigger and bigger and bigger, and then handling it with more invasive techniques. Right. So this is my take-home message, and this slide tells the whole story. I think water, it is extremely important for preventing stones.
Right. Yes.
I will stop sharing.
Yes, doctor. Thank you so much, doctor. And lots of queries and questions and doubts have been cleared by the presentation itself. Coming to the general queries and questions, there are a few viewers who have asked, but I will just take a moment and then I will go to their questions. One thing which I marked in your initial slide is that you said that there are kidney stone belts. So now how does the location or the geographic location help in the formation of kidney stones?
Yeah, there are various areas worldwide where it has been seen that the population has more propensity to develop stones. It can be the race, it can be the diet they are eating. The whole population may be eating a particular form of diet. Like in South India, the intake of protein, high protein diet is relatively low as compared to North India. Like meat eaters, non-vegetarian food eaters are more. So exactly to pinpoint the particular cause is difficult, but it's a whole range of reasons which are contributing to it.
Okay. So, how frequent do you see children having kidney stones, and what are the symptoms specifically in children? So, is there a difference in the symptoms with adults and children?
We come across children in our OPD and emergency management with stones. Yes, but the incidence is relatively lesser than the adults. But yes, there are. As you very rightly started off by saying that the infants can also have stones. Yes. Recently, we operated on a child with a big stone, a 5-year-old child. Oh. So you come across children with stones. And presentation, yes, most of the times they are able to present as if the same way as adults, like pain in the flank on one side of the abdomen. But sometimes small children are not able to actually localize the pain. They may have a vague stomach ache all over the abdomen, or they may have some cloudy urine. They may
or nausea,
cloudy urine. Yes, nausea and all. So these presentations can be little varied.
Right. We have a viewer, Doctor Nirali Sheth. So she says that yesterday she had severe pain because of stone, and what is the best painkiller or how to reduce the pain?
First of all, we need to be sure that the pain is because of stone. So we cannot presume that the any pain on one side or in the abdomen is because of stone. Yes, if you are a known stone patient, if you have undergone recently an ultrasound or an investigation which has shown that there is a stone in the kidney, the possibility of it having migrated down into the ureter and causing pain is high. So yes, that is a possibility. But my suggestion is that first get a proper evaluation done, whether it's the stone pain is because of stone or not. And second thing, the painkiller, we have this habit of taking painkillers at will, which is not a good recommendation. We come across people who have actually been taking painkillers for many weeks and months on their own, and somehow one in maybe 20, one in 30 patients may actually develop kidney dysfunction because of wrong intake of painkillers.
Yes.
So it will not be proper for me to recommend a particular painkiller on this platform. But yes, normally whatever pain medicine can be taken in emergency off and on, but at the same time, proper evaluation and proper guidance is mandatory.
Right. Even Dr. Surbi Kaul is asking the same question. Which is the safest analgesic to consume during pain? Yes.
There are different groups of analgesics, diclofenac and dotaverine. These are the usual combinations used. But definitely
it would vary from patient to patient, right?
Exactly. It varies from person to person. A healthy, normal adult without any other problems may consume a tablet or so in emergency, not otherwise. But I'll definitely not recommend it to take medications on your own in the elderly group, in the children, especially in pregnant females, again, or in patients who have other comorbidities like heart diseases, diabetes, or other issues. So you have to be very careful.
Is there any other way, like exercise or food intake, or wherein we can reduce the pain, or which helps in maybe excretion of the stone? Or
frankly, no. I mean, I have myself seen a lot of messages circulating on social media that do this and so on will go off.
Yes.
Practically, scientifically saying there's nothing we can do about it. But we have come across athletes who have got stones in their kidneys, small stone in the kidneys, and they run, they jump, and sometimes the stone in the kidney may actually get dislodged and go into the ureter, and may pass off by itself or may actually get obstructed. So that varies with the size. But practically, not much can be done that, do you do this and the stone will come out? Unlikely.
Right. I think to reduce pain, medication, and that too under proper doctor supervision is recommended.
Exactly. And what you can do, as I told you, my normal advice to people is make sure that your urine output is good. Because people keep on asking how much water we should take. So water intake depends on the season. Like in summers, obviously there's sweating, there's more of water loss from the body from other reasons. So the urine production will be less if you take less water. So water intake has to be regulated with the urine output. The target is that a person should average on an average pass urine in the range of about 1.5-2 liters. To make it simple, if a person is passing about 250 ml of urine each time, or 300 ml of 6-7 times if he is going to washroom, and every time the urine is clear, it's not concentrated, then you are doing a fair job. Then that's an indirect evaluation that yes, we are on the right path.
Right. Coming back to children, doctor, are the causes of stones in children the same as in adults?
Here again, if I go back to the slides, I did not go deep into the details because it's a presentation for the general public. But in children, the causes are really most of the time different. In adults, you are not able to figure out a cause. It may be because of less water intake and all. But in children, you are able to find a metabolic reason. As I told you, cystine stones, uric acid stones. These are formed in people who have some metabolic derangement, or the calcium may be actually excreting more of calcium. Kidneys may be excreting more of calcium in urine, which is called hypercalciuria. So these are the conditions where medical treatment or an evaluation may be helpful. And in children also, some children have some inborn diseases. They may have some anatomical abnormality in the kidneys. Kidney may be having some different shape, or there may be some narrowing of the tubes. This increases the possibility of stone formation.
Right. And what are the chances of the reoccurrences of stones? So it may vary from person to person. Yes.
Yeah, so the research and the data analysis people have done, it has been shown that if a person has formed a stone, an adult if has formed a stone, there are 50% more chance of forming a stone again.
Okay.
So, I mean, it's quite high. It's quite high.
Okay.
So, a stone found, and if it passes spontaneously, well and good, or if it's removed, then that's actually a warning sign for the person to modify his diet, modify his routine, and increase water intake so that the stone doesn't form again. But as compared to a general population, any other person, he has got 50% more chance of forming stone again in next 5 years.
Okay. In the next 5 years, and it may vary. I mean,
it may vary. Definitely, it's nothing hard and fast.
So
but there are some variety of stones like uric acid stones. Some people have gout. They take some medicines. They have high uric acid levels in the blood, and then consequently in the urine. So these people tend to form stones very frequently. If the stone passes, and again 6 months, 1 year down the line, another stone is formed. This is a group of people who really need to be very careful.
Right. So I think that the myth that the people have is like once we remove a stone, we will be sure of it that now we don't have any chances of getting it back.
Meenal, actually here I want to say I have come across some people in masses. There's in some maybe a particular group of people, they have a notion that if we touch a stone, if we remove a stone, the chances of forming again is high. This is actually not correct. They think that, and sometimes people say that अरे आप जैसा आप stone को break करोगे, निकालोगे तो वो तो चूरा रह जाएगा और फिर से बन जाएगा. आप पूरा नहीं निकाल सकते हो. I mean, this is something we need to clarify. Suppose there is a big stone in the kidney and you are doing an endoscopic procedure. You will not be able to remove it completely in one go, in one piece. Yes. Obviously, you are working under a camera, which is a high magnification camera. You are looking into each and every corner of the kidney and clearing it and dusting it off. So, but clearing it in one piece will mean that you have to make a big cut into the kidney, which is not advisable. Yes. So, these things a person should understand.
And are there any chances of patients having pre-kidney problems develop the chances of having kidney stones also?
As such, there is not a particular relationship specifically, but yes, if the kidney derangement is already there, then the urine production capacity of the kidneys will be relatively less, especially in the patients who are advanced kidney disease. So when the urine production is less, again the minerals which are the concentration of minerals in the urine will increase, the solubility will decrease, and precipitation and again consequent stone formation will be higher.
Right. How can we, again, there is, as you said in your slide also, there is no specific reason as to prevention of stones, but what are the general lifestyle changes we need to take? Again, I think that would...
this is a very pertinent and a very important question which everybody wants to know. So basically, eating a healthy balanced diet, cutting on your carbohydrate intake and cutting on your excess protein intake, protein shakes, people take in plenty, like we come across some athletes and some bodybuilders who take excess proteins. Excess of everything is bad. This is something which is a very important term which applies everywhere. Nature tries to balance everything, but whenever you try to play with nature, you do something in excess. That's a problem. So excess of carbohydrates or proteins should be decreased, and oxalate-rich food should be decreased. Oxalates are not required in the body, so we should decrease, like tea, coffee, cold drinks, dry fruit, fast food, nuts. These should be taken in moderation.
Right.
And at the same time, water intake. So these are the two principal things. Otherwise, you may search the internet, you may go to different people, but nothing works more than these two things.
Right. I think, Doctor, many questions related to stones during pregnancy have been covered in your presentation. And you have very, very systematically showed even the procedure also of removal of stones, especially during pregnancy. So again, to come back to that, I think after seeing the slides and all, it is very, very clear that it is not as risky as people would think to maybe have a stone and even the removal of it.
Exactly. And stone, people presume that stone is inside the ureter or kidney stuck up and doesn't matter. But in few people, it really matters in the long run. To make the public aware of the problem, because we are the people, every fourth patient, fifth patient in the OPD is a stone patient for us. So we come across a lot of variety of people. And I have seen patients where there was a stone, the patient had a stone pain, he did an ultrasound, he found there was maybe a 6, 7, 8 mm stone in the ureter, and he took some painkiller, and that's the end of the story. He is comfortable, there is no pain, and he feels that the stone is gone. And what has happened, that stone may become silent also. It doesn't cause pain all the time. If it's not moving from its place, it may remain silent.
Right.
And fact is that the same patient, 2-3 months down the line, he comes with another episode of pain or some other illness, gets an ultrasound done. The kidney actually is damaged. And if it has been seen that if you wait for more than 3 to 4 weeks for a stone in the ureter, here we should be very clear. If the stone is inside the kidney and it's not obstructing, you may easily take your time, 2 months, 4 months, 6 months, and try whatever medical treatments, whatever alternative medicine you want to take. Fair enough, nothing wrong with it.
Okay.
But if the stone is somewhere in the ureter, it's obstructing the ureter, if it's somehow obstructing the flow of urine from that kidney, then waiting for more than 3 to 4 weeks is not advisable, because that is the time, research has shown that is the time when the permanent damage starts occurring in the kidney. Okay. And even if you remove the stone, maybe 2 months down the line, 3 months down the line, the kidney has already lost a good amount of its function, which is non-recoverable.
Okay.
So losing your kidney function, kidney is a very vital organ of the body which cannot be sacrificed.
Yes.
Losing a lot of kidney function to a stone, it really pains us.
Yes.
So people need to be aware, they need to be focused, they need to just take advice and follow the advice sincerely.
Right. This was exactly my next question, that there are cases, there are people who feel that, okay, I have a stone but it's not causing me any pain, I don't have any pain, it's fine, so why would I go for the removal of it, and why go through all the pain, all the task and process, and so yes, but it is very important, as you said.
These are actually the first-hand experiences we have, and we would like to share this among the masses, that take your time in handling the kidney stones, smaller kidney stones. Maybe they might not do any harm if they are silently sitting in the kidney for some time. But when the point of handling the ureteric stones is concerned, with the stones which have migrated down, don't waste time, because they can be very much harmful for the kidneys.
Right. Coming back to children, doctor, like if a mother or if the family of the child has a history of stones, either the father or the mother, or there is a history of stones, then I think the parent would be more aware of the probability of having stones in their children. But again, how will a mother exactly know that okay, this is the time when I need to show my child to a urologist or to a doctor and tell the doctor that this might be the reason?
Yeah, this is interesting. Let me tell you, as per the statistics, a child having a family history has about 2 to 16 times more chances of forming a stone.
Okay.
Or doing an ultrasound at I will not say if the child is asymptomatic, no problem at all, that you should just go in at 1 year or 2 years or 3 years of age for evaluation. But yes, when the child grows up, maybe 5 years, 6 years, getting a basic ultrasound done for the abdomen in such group of patients where the family is very strong is advisable.
Okay.
And at the same time, taking precautions from very early onset, making the child understand the risks involved and water intake, making him aware how much water he should take, keep him hydrated. Here I would like to point out, there are some people who might take like 2-3 glasses of water in the morning and then take 2-3 glasses of water in the late evening, and they think we have taken 6 glasses of water, that is sufficient.
Yes.
But this is actually not the way to take water. It has to be at a regular intervals. Couple of glasses, 1 glass, 2 glass, every 2-3 hours, because there are phases of relative dehydration in the body. And that is the time when these crystals get time to get jammed up together and form stones. So adequate hydration at regular intervals is the key.
Right. I think that was very, very interesting, doctor. And thank you so much for clearing our doubts and myths and showing us the facts related to kidney stones. Thank you so much. We are thrilled to have this webinar with you, doctor. And I'm sorry, just a moment. I think am I visible, doctor?
Yeah, I can see you, ma'am.
Okay, fine. Yes.
So I think it's a privilege for me to be part of this initiative by you, and whatever queries if you get all along throughout this in future, you can pass it on to me. I'll be really happy to reply them through mail or whatever way you want.
Yes.
And the Maatri as such is doing a wonderful job, and I really appreciate your efforts.
Thank you so much, doctor. I also would like to inform our viewers that they can still post their questions, and as Dr. Sandeep said, we will connect the questions to Dr. Sandeep, and we will try to give as many answers and to the questions coming in the post. Thank you so much again. Thank you all viewers, and Dr. Sandeep Harkar, it was a privilege to have you with us today.
Thank you. My pleasure, ma'am. Thank you.
Yes.
Thank you.
Okay. Bye-bye, doctor.